poke my head.
Alright. Okay. Hello everyone. My name is Lexi Worland, and I'm going to be doing a presentation on delirium prevention in the ICU. This is part of my final semester of my BSN program for my Capstone. So the problem that we're going to be addressing today is ICU delirium. Delirium is defined as a state of clinical dysfunction presenting as disorientation, agitation, sleep disturbance, and aggression at times. Risk factors for delirium are clinical acuity, poor sleep hygiene, overstimulation, particularly at night, a history of anxiety or depression, immobility, especially when it's due to restraints, mechanical ventilation, and also sedation medications. There's a high prevalence of ICU delirium on the MedSurg ICU at Gateway, and we know this just by looking at our patient population and our own clinical experiences. Delirium is associated with a longer length of stay in the hospital and an increased risk of morbidity and mortality. So the next part of this presentation, I'm going to be going over some evidence-based practice, literature, and different studies. So a study was conducted at the University Hospital in Turkey on the effects of music therapy on pain, anxiety, agitation, and delirium in the ICU. This study was a single-blind, stratified, randomized control trial. There was 36 delirium-positive patients in an open ward internal medical surgical ICU. One group received allocated music intervention, the second received allocated noise reduction, and the third received their usual ICU care. The intervention sessions were performed 1 hour in the morning and 1 hour in the afternoon for a total of 2 hours per day for 5 consecutive days, equaling 10 hours total for the study. Compared to the control group, the music group outperformed the other two groups significantly in reducing delirium. When compared to the noise reduction group and when compared to the standard care group, overall the music group performed better. The next study is the effects of music therapy on ICU-induced anxiety. As mentioned before, we know that anxiety is a risk factor for developing ICU delirium. So this study was conducted on patients in the ICU of a tertiary hospital in the northern part of India. The ICUs studied included the medical, surgical, and burn units. The intervention was tailored music therapy created by a music therapist that was then recorded on an MP3 player and played for 20 minutes 3 times a day for 3 days. The intervention group consisted of 35 people, and they received music therapy as well as the standard of care. The control group was also 35 people, and they only received their standard of care in the ICU. On day 4, the intervention group reported a decrease in anxiety from baseline, whereas the control group reported no change in anxiety. Also, the intervention group had a lower mean anxiety score than the control group, so from there we can infer that they were at a lower risk for delirium. The third study that I'm covering is receptive music therapy receiving mechanical ventilation. So again, we know that anxiety is a risk factor, and that's what this study focuses on, as well as the reduction of use of pharmacological therapies like high doses of sedative medications. So a study evaluated the use of music therapy to reduce anxiety as an alternative to pharmacological therapy. The population studied included mechanically ventilated adults 18 years of age or older and a medical surgical ICU in Virginia. 61 patients were randomly selected for the control group and 57 for the intervention group. The intervention consisted of patient-centered live music therapy provided by a music therapist via acoustic guitar with humming or quiet singing for 30 minutes per day. There was a statistically significant improvement in both measurements in the intervention group compared to the control group. So the fourth study is on decreasing delirium through music. A randomized controlled clinical trial was conducted using a 3-arm single-blind method, and it was done to determine if music or audiobook therapy was effective in reducing delirium in the ICU. So this was conducted on adults who were admitted to the ICU and receiving mechanical ventilation for 24 to 48 hours. There were 52 participants, and each patient received 2 sessions of 1 hour of either the music, audiobook therapy, or let's see here, noise reduction, I think was the last one. So they received 1 session in the morning and 1 in the evening, and these patients were randomly assigned to one of the 3 test groups. And the study was analyzed by comparing which of the 3 groups was the most effective in reducing delirium and anxiety. When analyzing the reduction in anxiety, the researchers monitored heart rate and other vital signs, and it was found that music was effective in reducing the heart rate and diastolic blood pressure, which is an indicator of decreased anxiety. It was also found that patients who received slow instrumental music received lower doses of Haldol, opioids, propofol, Seroquel by day 7 than the other 2 groups. The last one is on quality improvement intervention on sleep and delirium. We know that sleep disturbance is a known contributing factor to delirium, so that's what this study focuses on. It was conducted in a tertiary care academic medical center analyzing the implementation of environmental interventions to promote nighttime sleep quality and daytime wakefulness. This study was conducted on a 12-bed medical surgical trauma ICU and a 20-bed cardiac ICU for a total of 646 patients included in the study. They used a pre-intervention versus post-intervention analysis method, and the intervention was a bundle comprised of promoting daytime wakefulness through turning on the lights, opening the windows and doors, putting on glasses and hearing aids if the patient has those, and encouraging physical activity and cognitive activities, and no caffeine after 3 p.m., and avoiding napping. The nighttime interventions began at 10 p.m. at night and included turning off the TV, closing doors and curtains, minimizing alarms, dimming the lights, limiting visiting hours, and encouraging family to help with sleep promotion, and clustering patient care and offering eye masks and earplugs to patients. So after the implementation of the bundle, there was a reduction in the number of delirium days across a 14-day span compared to pre-intervention rates. It can be concluded that the promotion of normal sleep-wake cycles reduces delirium in the ICU. So next we're going to kind of go over how this applies to our unit and how we're going to implement change. So in adults admitted to the intensive care unit, how does the reduction of anxiety and promotion of sleep-wake cycles through music therapy compared to the current practices of pharmacological therapy and the current delirium bundle affect delirium rates? So our current practice is contributing to high numbers of delirium positive days in the ICU, and therefore a change in practice is warranted. The current practice heavily utilizes sedative medications and restraints when delirium becomes progressive, and these interventions further contribute to delirious states. Prevention of delirium and reduction in the number of delirium positive days should lead to a reduction in the use of pharmacological interventions. The current delirium bundle includes reduction of noise and lights in the evening, putting on eyeglasses and hearing aids, and promotion of reorientation activities. While these are beneficial interventions, they're not enough. Introduction of music therapy has been shown to reduce delirium rates in the ICU. And music therapy, in addition to the current delirium bundle, should reduce the rates of delirium based on the data previously presented in this presentation. So the recommendation for evidence-based practice, the data presented and mentioned in the studies demonstrates that music therapy is an appropriate and effective intervention to prevent delirium in the ICU. This is an intervention that requires minimal resources and time. It's budget-friendly and it can be implemented rapidly. And since nurses spend the most time with patients, they'll be the ones providing the therapy. The plan is to provide education on the change in practice to the entire multidisciplinary team so they're aware of the change so that therapy may not be disrupted. The second step is to implement the change in practice, and the intervention will be implemented by nurses completed each shift at 9 a.m. and 2100 p.m. The third step in the PDSA cycle is study. So the intervention will be studied through monthly analysis of delirium positive, CAM ICU, and SAS scores. Both of these assessment tools are already completed once a shift by the nurses on our unit during their first assessment. So this is nothing new. The final step is to act on comparison delirium rates and further revise the intervention plan as needed. So, basically, to kind of sum everything up, the plan is for us to use music therapy for about an hour once a shift, and we already have music therapy on the iBeds, so we'll just use that and try to have
we have it. Like, I forget that the beds make noise.
Yeah, so we just use that and then kind of have quiet time and try to keep it as uninterrupted as possible. So some questions for you guys. Is the intervention appropriate or feasible for the workplace? Discuss rationale and suggestions for changes.
I mean, like you said, it's on the iBed, so I feel like it's pretty easy for us to implement. I mean, it's not like we have to sit there and make sure it's going. We can, like, pretty well just set it and then set a timer on it. So I feel like it's pretty easy to actually manage.
I think it's feasible because 9 p.m. is turn time, 10 p.m. is INO time, so I mean, and heaven forbid you forget at 9 p.m. As long as you do your hour, it should be beneficial. As long as it's, you know, not in the middle of the night.
Mm-hmm. And it's kind of that time whenever we're supposed to make them wind down anyway, turn out all the lights, do all the stuff anyway. How will the intervention positively and or negatively impact the nurse's obligation to provide holistic, culturally sensitive, and patient-centered care to the identified population of patients?
I don't know if there's really any negative impact I can think of. I mean, positively, like you said, it can reduce anxiety. Like, I feel like a lot of struggle for people to get to sleep is that they're anxious about what's going on the following day or what's going on throughout the night. So I feel like if you provide something to help decrease that anxiety before they go to bed, I feel like it could help provide more holistic care for them.
And the better they sleep, the better chances are that they have less delirium and less confusion, less long stays in the ICU. Sooner they can get home or to rehab or wherever they need to be.
Okay. What are the legal and ethical implications for nurses who will be implementing the intervention, such as allocating resources to implement the intervention, sustaining the intervention, and staff education?
I mean, it can be discussed in huddle, in our daily shift huddle, but as far as legal and anything, I don't think that should be a problem.
Maybe there's any issues with it. I think staff education would be like really the only thing. Just letting them know why we do it, the importance of it, and how to implement it.
How will implementing the intervention positively and or negatively impact the interprofessional multidisciplinary team, such as workload, job satisfaction, ability to provide safe care, and ability to participate in evidence-based practice?
I mean, there could potentially be less sitter needs. Using that staff elsewhere. I forget the rest of the question. Sorry.
Basically, like, do you think that it's gonna have any sort of like negative impact?
Negative? No.
Okay.
I don't.
Do you think it add too much to the workload?
Anybody can turn the music on.
Yeah, I mean, it can
Into your
include
routine.
texts. It can include literally anybody.
Yeah.
You can teach family how to do it as well as they know how to do it appropriately.
Mm-hmm.
Or even if the family wanted to select music that the patient like gospel music or something, like we could use that as well.
Mm-hmm.
Probably nothing like rap or something, but
Yeah, I was
something
gonna say
like
that
soothing.
the only thing is like,
and explaining to the family why we're doing it might be helpful as well.
yeah, it needs to be like low stimulation
Mhm.
music. What is the workplace's process for implementing the intervention, such as using an evidence-based practice model of the PDSA cycle, or implementing a quality improvement project?
Isn't there something called like a chip, and you submit like your ideas to it.
I think I've heard of that.
I,
don't know what
I'm
it
pretty
stands
sure it
for.
is. Like, you can submit a chip, and like not that long ago, we got an email that the people in PACU or whatever, for people that had eye surgeries, they submitted this chip, and now they have like these little ice pack things for their eyes or something. Like, I think that's how they got that process. So I feel like the same could be applicable there.
What are the barriers to implementing the intervention? How can these barriers be overcome?
A big barrier is when they don't put our patients on an ICU bed, because they don't make they don't have that function. But if there's not a bed available, there's not a bed available. But we can maybe find meditation music on like a music channel, or pull it up on the computer in the room or something. There's definitely ways around it, but it's definitely a barrier.
I think it's also like lack of like knowledge of people. I just don't think people know that all of the ICU beds have that setting that you can turn on the music as well.
Who are advocates to involve in implementing the intervention? Why are these people advocates?
Management. You, because you did the research. Management for obvious reasons.
Yeah.
Team leaders.
Yeah, I feel like even for like sitters and everything too, if they have like if they could see like a before and after, or if they can like see patients like get it versus those that don't. So I feel like they'd be advocates of it because it's less of a sitting need if they want if the patient is relaxed.
Alright, well, that's all. Here are my references.
Good job.
Good job. Maybe I should go turn my music on now. It's not too late.
It's not too late.